Welcome. I'm going to be discussing data from a recent publication in Lancet Respiratory Medicine in which we evaluated baseline exhaled nitric oxide as a prognostic biomarker for subsequent severe asthma exacerbations. The data from this came from the clinical trial Liberty Asthma Quest, which evaluated the efficacy of dupilumab in patients with moderate to severe uncontrolled asthma. I'm Dr. William Busse. I'm Emeritus Professor of Medicine at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin, and in the Division of Allergy, Pulmonary, and Critical Care Medicine. I've had a long-standing interest in the roles of airway inflammation, the role of airway inflammation to asthma exacerbations, and also methodologies for improved management of patients with severe asthma, and have been participant in a variety of clinical trials evaluating some of the newer biologics in the treatment of severe asthma. So let's just set the stage looking at the background, the objectives, and methods of the analysis that we performed. Well, we do know that exhaled nitric oxide has emerged as an important marker and indicator of underlying type 2 inflammation in the airways of patients with asthma. And it may also have the capacity to potentially inform clinicians and patients in the better management of patients with moderate to severe asthma. We know that the measurements of exhaled nitric oxide in the airway are straightforward in testing. They can be detected in a safe, simple, and non-invasive exhaled breath test. And exhaled nitric oxide can be rapidly and inexpensively assessed during routine clinical assessments when patients are being seen for care of their disease. Exhaled nitric oxide also has the potential as a prognostic biomarker in asthma, but its value amongst other recognized indicators such as blood eosinophils, serum IgE, and clinical determinants really has not been fully established. So the objective of our analysis was to assess the added prognostic value of exhaled nitric oxide to blood eosinophils and prior severe asthma exacerbations for the subsequent risk of asthma exacerbations. So to accomplish this goal, we performed a post hoc analysis of a 1-year or 52-week double-blind placebo-controlled trial entitled Liberty Asthma Quest trial, which evaluated dupilumab in 2 doses versus placebo. The data were examined from 620 patients ranging from 12 years of age and older who had moderate to severe asthma and were randomly assigned in this trial to placebo. We had multiple variable prospective analysis of the relationship between baseline exhaled nitric oxide through a variety of categories or levels and the annualized severe exacerbation rate over this period of time. So total events were the response variable measured. Covariates included baseline exhaled nitric oxide, our marker of interest, post-bronchodilator FEV1, the asthma ACQ-5 score for symptoms, blood eosinophil counts, serological IgE, smoking history, number of severe asthma exacerbations within 1 year prior to enrollment in the study, and time since last exacerbation and age of onset of asthma. It was a wide-ranging, multivariate analysis. So here are some of the characteristics of the patients enrolled in the Quest trial. As I'd indicated, they were 12 years of age or older. They had a history of persistent asthma. They needed to require a medium to high-dose inhaled corticosteroids plus up to 2 additional controller medications. FEV1s needed to range from 80 to 40% predicted. They needed to demonstrate reversibility, greater than 12%, improvement in FEV1, and 200 ml. Their ACQ score needed to be greater than 1.5. They needed to demonstrate that their disease was not controlled. And they had to have at least one exacerbation in the previous year. So here are some of the ways in which we analyze the data in relationship to annualized severe exacerbation rates. We assess by baseline exhaled nitric oxide at various cut points, less than 25 parts per billion, 25 to 50 parts per billion, and above 50 parts per billion. We did cross-classifications by baseline eosinophils, again at various cut points, less than 150 cells per microliter, 150 to 300 cells per microliter, and greater than 300 cells per microliter, and also in relationship to prior asthma exacerbations, 1 or 2 or more. And all of these data were adjusted for baseline ACQ scores, post-bronchodilator FEV1, and other clinical characteristics. So here are the results. This is the data from Figure 2, and what it looks at is the annualized exacerbation rates at various cut points of exhaled nitric oxide, less than 25 parts per billion, which is less than 0.8 exacerbations per year, 25 to 50, which increases to over 1, about a 33% increase, but not statistically significant. But when the exhaled nitric oxide was greater than 25 parts per billion, the risk for an asthma exacerbation increased to 1.2 exacerbations, and this is highly statistically significant. This indicates that the presence of exhaled nitric oxide, independent of blood eosinophils and other characteristics, is a marker of a risk for asthma exacerbations. These are new observations. We then evaluated the risk for asthma exacerbations over this 52-week period of observations in relationship of cut points of exhaled nitric oxide, as shown on the horizontal line, less than 25 parts per billion, 25 to 50 parts per billion, and greater than 50 parts per billion in relationship to blood eosinophil counts on the vertical axis, less than 150 cells per microliter, 150 to 300 cells per microliter, and greater than 300 cells per microliter. When exhaled nitric oxide is less than 25 parts per billion and the blood eosinophil count is less than 150 parts per billion, the risk for an asthma exacerbation is about 0.6. However, when the blood eosinophil counts are 150 to 300 cells per microliter and the exhaled nitric oxide is between 25 to 50 parts per billion, we're increasing the risk for an asthma exacerbation, which is maximal at the risk level when the blood eosinophils are 300 cells per microliter and the exhaled nitric oxide levels are greater than 50 parts per billion, and it increases it up to approximately 1.8, which is highly significant. So these two biomarkers, when present together, appear to have additive effects as far as predicting the risk for asthma exacerbations. The other thing we looked at was the history of prior asthma exacerbations. We looked at individuals who at time of enrollment had one prior asthma exacerbation in the previous year and those who had 2 or more during the previous year. We know that the past history of asthma exacerbations is also a predictive risk for asthma exacerbations, and we wanted to look at this risk in relationship to exhaled nitric oxide and also blood eosinophil counts. On the left-hand side, we are looking at individuals who had one prior severe asthma exacerbations, and we looked at it in relationship to exhaled nitric oxide less than 25 parts per billion and more than 25 parts per billion, and blood eosinophils less than 150 cells per microliter or greater than 150 cells per microliter. And as you can see, again, when these are when the exhaled nitric oxide and the blood eosinophils are low, the risk in this group was about 0.4. However, when both of these points are elevated, exhaled nitric oxide and blood eosinophils, again, there's an additional risk for an asthma exacerbation, as indicated by the bars at the top. If, however, we expand this to individuals who had had 2 or more asthma exacerbations, we also find the same relationship. This is indicated by the increased likelihood of individuals who have elevated exhaled nitric oxide and elevated blood eosinophils and 2 asthma exacerbations. These are the individuals who also appear to be at greater risk for asthma exacerbations. So lastly, we also wanted to look at the multivariate prospective analysis of our studies in relationship to some subgroups, looking at exhaled nitric oxide greater than 25 parts per billion, eosinophils greater than 150 cells per microliter, and patients who had 2 or more exacerbations in the previous year. This group of individuals has an annualized rate of severe asthma exacerbations of 1.3. Its relative risks is 3.6, which is highly significant, indicating that patients with elevated exhaled nitric oxide, elevated blood eosinophils, and 2 or more asthma exacerbations are patients who are at the greatest risk for having an asthma exacerbation in a year period of time. So let's analyze what these data mean. I think first of all, the data show that the use of the available blood markers, blood eosinophils and exhaled nitric oxide, to identify the presence of type 2 inflammation and susceptibility for future asthma exacerbation has been documented. We know that exhaled nitric oxide testing is easy, safe, and non-invasive, and we also know that it is reproducible and reliably measured. We saw this in the QUEST study. I also feel that exhaled nitric oxide is currently underused in clinical practice. It has an advantage of being rapidly and inexpensively available to assess patients for type 2 airway inflammation and also their risk for future exacerbations when patients are undergoing routine clinical care. However, the data to identify the specific contribution of exhaled nitric oxide independent of blood eosinophils has been until this point limited. So what we have seen is that high levels of exhaled nitric oxide by themselves are associated with an increased risk for severe exacerbations when patients are followed over a 52-week period of time, and this is independent of clinical standard characteristics. Our findings underscore and I think substantiate the value of exhaled nitric oxide as a measure to identify asthma patients who are at greater risk for asthma exacerbations, and also importantly, are potential candidates for the presence of type 2 inflammation, which can serve as a marker of the potential benefit for therapeutic intervention with biologics. Our findings from this analysis, I think, also support the use of exhaled nitric oxide as a prognostic biomarker when combined with blood eosinophils and the previous history of severe asthma exacerbations to identify patients who have uncontrolled asthma. It is of moderate severity, and it is this group of individuals who appear to be at the greatest increased risk for future asthma exacerbations. So what can we say in conclusion? Well, in patients with moderate to severe asthma, which is uncontrolled despite receiving standard of care such as high-dose or medium-dose inhaled corticosteroid, in this setting, exhaled nitric oxide provides an important prognostic bit of data on the risk of future severe exacerbations, and this is over and above that of the known prognostic indications from elevated blood eosinophils and independent of standard clinical characteristics such as lung function and asthma control scores. So thank you very much for your attention. We feel that these data are important in our greater understanding and recognition of patients who have type 2 inflammation, and also tells us, importantly, who are patients who are at greatest risk for asthma exacerbations and who might be the best candidates for intervention with type 2 biologics.